Welcome to the deep dive. Today we're digging into something quite specific, Splanchnic Artery Aneurysms.
hmm
Now, these aren't your everyday topic, but they're basically weak spots, bulges in the arteries supplying blood to abdominal organs. And well, if they rupture, it can get very serious very fast.
Exactly. And what's really interesting, I think, for this deep dive is we're kind of grounding it in a really foundational paper from 1986,
Yeah.
Stanley and his colleagues.
Right.
It really set the stage for a lot of what we know,
Hmm.
but we'll also, look at it with a modern perspective too.
Yeah, and those early numbers, they really make you pause. The study found almost 22% of cases presented as emergencies.
Yeah,
And tragically, over 8% were fatal. So that really tells you why it's so important to get a handle on these things, where they happen, why they're significant, and how we actually manage them.
absolutely.
So that's the plan for today. Let's jump in.
Okay, let's do it. I think the best place to start is probably just mapping out where these things typically occur. The 86 paper gave a really clear breakdown of frequency by location.
Okay, so where are we most likely to find them?
Well, the splenic artery, that's the one going to the spleen, is way out in front, most common by far.
Okay.
After that, it drops off. You get hepatic artery for the liver, then superior mesenteric artery, that's small intestine, part of the colon.
Right.
Then celiac artery, which hits the stomach, liver, spleen area. Then, let's see, gastroepiploic for the stomach. Jejunal ileocolic, again, intestines.
So quite a few potential spots.
Yeah. And then even less common are the pancreaticoduodenal pancreatic and the gastroduodenal arteries.
Huh.
So really, the splenic artery is the main hotspot. The key takeaway there is just they aren't random. Some arteries are just much more susceptible.
Okay, so splenic artery aneurysms the most common. What's driving those? What are the key things we need to know there?
Well, the original study pointed to a few associations. Arterial fibrodysplasia was one that's a condition affecting the artery walls themselves, makes them abnormal.
Okay.
Portal hypertension, so high blood pressure in the liver circulation. And interestingly, multiparity, having had multiple pregnancies.
Huh. And do they cause symptoms often?
Most don't, actually.
Hmm.
But the paper noted maybe up to 20% can be symptomatic.
And you mentioned pregnancy. That sounds like a particularly risky combination here, right? I remember some stark numbers in the paper.
Oh, absolutely. Very stark. The estimated rupture rate during pregnancy was pegged at 95%, extremely high.
Wow.
And the outcomes were just devastating. Mortality around 70% for the mother, and tragically, 95% for the fetus.
Goodness.
You can see why the paper strongly recommended surgery in certain cases.
Uh-huh.
If the aneurysm was bigger than 2.5 centimeters, if the woman was pregnant, or even just of childbearing age, or if she had any symptoms at all.
Yeah, that makes the proactive approach seem critical.
Definitely.
What about outside of pregnancy? For splenic artery aneurysms?
Still a serious concern. A rupture in a non-pregnant patient still carried a significant mortality risk, around 25%.
Okay.
And the researchers did this interesting calculation. They tried to weigh the risks. If there's roughly a 2% chance of rupture per year, and that rupture has a 25% chance of being fatal,
Right.
you compare that to the risk of elective surgery. And they figured the risk of dying from the elective surgery needed to be really low, less than 0.5%, to really justify operating on an aneurysm that hadn't ruptured yet.
That's a fascinating way to think about the threshold for intervention.
Yeah.
Okay, let's shift gears. Hepatic artery aneurysms. The liver supply. What causes those?
The causes there tend to be a bit more diverse. Atherosclerosis, plaque buildup, that's a big one.
Mm.
Also something called acquired medial degeneration, basically the artery wall weakening over time. Trauma can do it. Infection too, sometimes linked to illicit drug use, unfortunately,
Mm-hmm.
and other underlying artery problems.
And location-wise, within the liver's network, where do they pop up?
Mostly outside the liver tissue itself, about 80% are extrahepatic.
Mm.
The other 20% are intrahepatic, actually within the liver.
Okay.
And 86 paper broke it down further. Common hepatic artery, that main trunk, got about 63%. Right hepatic artery, 28%. Left hepatic, only 5%. And sometimes both, about 4%.
And if they rupture, where does the bleeding go?
Interesting point. It could rupture into the biliary tract, the bile ducts,
Uh,
or just into the peritoneum, the abdominal cavity lining. And apparently it happens with about equal frequency either way.
so given all that, what was the thinking on treatment back then?
Well, considering the rupture rate was maybe less than 20%, but if it did rupture, the mortality was around 35%.
Still quite high.
Yeah. So the general recommendation was operative therapy for most of them. The potential downside of a rupture was just seen as too severe to ignore in many cases.
Makes sense. Okay, next on the list. Superior mesenteric artery aneurysms. supplies the intestines. The paper seemed to finger one main culprit there.
It did, yeah. Infection is the big player here, accounting for maybe 60% of these, specifically what they call mycotic aneurysms caused by bacteria.
Right.
And often it's linked to non-hemolytic staph bacteria from left-sided bacterial endocarditis and infection on the heart valves.
So an infection seeding elsewhere and landing in that artery.
Exactly. Shows how things are connected systemically.
And the danger, rupture risk, and preferred treatment.
They didn't know the exact rupture rate, but the authors felt it was relatively high. So because of that concern, the go-to treatment was surgery actually removing the aneurysm, aneurysmectomy, and then properly reconstructing the artery. Not just tying it off, because you really need to preserve blood flow to the gut.
Absolutely critical for the intestines. Okay, celiac artery aneurysms.
Celiac. Reported rupture rates, there were around 13%, but if it happened, mortality was high again, about 50%. And an interesting finding was that maybe half of these patients also had aneurysms elsewhere, like in the aorta or other visceral arteries.
Suggesting a more systemic issue for some people?
Potentially, yeah.
Yeah.
Some underlying weakness. The proposed treatment was similar. Surgery to remove it and then reconstruction, often using a piece of saphenous vein from the leg as a graft.
Got it. Now let's talk gastric and gastroepiploic arteries stomach supply. These seemed a bit different in how they showed up.
They did. The paper called them mostly acquired, often from that medial degeneration, the wall weakening, or maybe inflammation around the artery. Atherosclerosis seemed secondary.
Okay.
But what was really striking was how often they presented after rupture, like 90% of reported cases, and often with no warning signs beforehand.
Wow, that's dramatic. Just suddenly an emergency.
Pretty much.
And what kind of rupture? Bleeding where?
Most commonly, about 70% was bleeding directly into the GI tract. You'd see that as vomiting blood or blood in the stool.
Oh, okay.
The other 30% was intraperitoneal hemorrhage bleeding into the abdominal cavity.
And the treatment approach?
Depended on location. If it was outside the stomach wall, simple ligation, just tying off the vessel, might work. But if the aneurysm was within the stomach wall itself, they recommended excision along with removing part of the stomach, a partial gastrectomy.
Makes sense. Need to get the source.
Yeah.
Okay, last group. Pancreaticoduodenal, pancreatic, and gastroduodenal artery aneurysms. Sounded like these pose some unique problems.
Yes, definitely challenging. They're often tied to inflammation nearby, usually from pancreatitis.
Oh, okay.
The inflammation can directly damage the vessel wall, or sometimes these food cysts, fluid collections from pancreatitis, can erode right into an artery.
Nasty complication.
Very. Patients often have epigastric pain, and rupture is really common, maybe up to 75% in some reports, especially if there's active inflammation. And that leads to terrible mortality rates, approaching 50%.
Goodness. And how are those managed back in '86? Sounded tricky.
Yeah, tricky is the word. The paper mentioned using transcatheter embolization, blocking the vessel from the inside with a catheter to try and control acute bleeding.
Okay, a less invasive option even then. Sort of. But they also noted high complication rates with it. And just doing simple surgical ligation was really difficult because the anatomy there is so complex, lots of small, important vessels packed together.
Right, a delicate area. So that really paints a detailed picture based on that landmark 1986 work. But, medicine doesn't stand still. How has the thinking, and crucially the treatment, evolved since then?
That's the key question, isn't it? And later commentaries really highlight the huge impact of better imaging. Things like MRI, MRA, CT scans, CT angiography.
Right, we can see things much better now.
Much better, much earlier. We're finding these aneurysms far more often now, frequently when they're smaller, totally asymptomatic, before they cause trouble. That's a massive shift.
That early detection has to make a world of difference.
Absolutely. And alongside that, the explosion in endovascular therapies has been, well, truly transformative.
Meaning catheter-based treatments.
Exactly. We now have this whole toolkit of minimally invasive options that we can deploy using catheters, even for really complex aneurysms. It allows for a much more tailored approach for each patient.
I imagine, though, since they're still pretty rare overall, figuring out their natural course, what happens if you just leave them alone, might still be tough.
You hit the nail on the head. That natural history is still not perfectly understood because they are relatively uncommon. Even with larger case series now, there's always a risk of bias, right? You might be reporting on the more unusual cases or the ones successfully treated.
Yeah.
But, recent data, like a big systematic review from 2019 looking at over 2,800 aneurysms, suggests many small ones tend to grow slowly, if at all, and often don't rupture. but a significant number still present ruptured, so we can't get complacent.
Okay, so tell me more about these newer endovascular techniques. What are the upsides? Any downsides?
Sure. So techniques like embolization, blocking the vessel off, sometimes with coils,
Coiling, right?
or using covered stents, which are like reinforced tubes to line the weak artery wall. The big advantages are clear. Minimally invasive, shorter hospital stays, quicker recovery, potentially fewer major heart complications compared to big open surgeries.
Sounds good, but there's always a but.
There often is. With endovascular, we sometimes see higher rates of needing another procedure down the road, a reintervention. There's also something called post-embolization syndrome, kind of a temporary flu-like reaction.
Okay.
And small risks like the coils moving, though thankfully major problems where the catheter goes in are usually pretty low.
So it's always a trade-off, weighing the pros and cons for each specific case.
Precisely. And you see this reflected in current guidelines, like the Society for Vascular Surgery's 2020 guidelines. They generally recommend intervention for most pseudoaneurysms.
Yeah.
Those aren't true aneurysms contained by all artery layers,
Mm-hmm.
and for mycotic ones, the infected ones. And also for many larger true aneurysms, even if they're asymptomatic, just because of that rupture risk. The fundamental goal hasn't changed. Stop it from expanding and rupturing, but keep blood flowing downstream if possible.
And you can achieve that goal now with open surgery or these endovascular methods.
Correct. And the specific location matters hugely. Remember the splenic artery?
Yeah, the most common one.
Because it often has good collateral circulation, other vessels that can pick up the slack, simply ligating or embolizing the aneurysm there, blocking it off, is often a perfectly good option without starving the spleen of blood.
Ah, so the anatomy dictates the strategy sometimes.
Absolutely. Which is why it always comes back to a very personalized approach. You have to look at the specific aneurysm, the patient's health, the available techniques, and make the best call.
Right. Which, in a way, brings us back to that '86 study. While our tools have dramatically improved, that early work was so crucial in just defining these different types of aneurysms, highlighting their unique causes, and really hammering home the potentially terrible outcomes if they weren't treated.
Could agree more. It really crystallized the dangers and pushed for early intervention, which back then primarily meant open surgery, to avoid those really high rupture mortality rates. That was the core insight. These rare things are dangerous if ignored.
So, wrapping this up, it seems clear that Splanchnic artery aneurysms, while maybe not household names, are this diverse group of conditions. And understanding them, where they occur, why the risks is really vital because the consequences can be so serious. And while that 1986 paper laid an essential foundation, the story since then has been one of massive progress in imaging and these less invasive endovascular treatments, really shifting how we can manage them, often much earlier.
That sums it up nicely. I think the main takeaway for listeners is this gives you a good overview, but every single case is unique. It needs that careful, tailored approach, considering everything about the aneurysm and the patient.
Definitely. And maybe a final thought for you to consider, given these incredible leaps in imaging and endovascular tech we've seen just since 1986, how might the strategies for managing these aneurysms evolve next? What new challenges or maybe new opportunities might pop up as we learn even more about these uncommon but important vascular issues? Thanks for joining us for this deep dive.